diagnosis, and after that Dr. Shaugato Sarkar will touch upon few points regarding the receptor, because here the autonomic function and the receptor is very much important, and followed by management. Dr. Shambho will take care about that, and this will be the flow of the presentation for today. So
Trying to interrupt Sumalada.
yes.
After you finish, I will present mine. Then Shubhodaya will take the next session. Okay.
Okay, sure. Okay. Okay, so first of all, we might be aware about this terminology, that what is DHR. DHR stands for drug hypersensitivity reaction, and drug hypersensitivity reactions are actually reactions that are resulting from unintended and unwanted stimulation of the immune or inflammatory cells by a medication. And if we look into the statistics, it's very important and notable point that 6 to 10% of all the adverse drug reactions, but up to 10% of the fatal reactions they are actually causing. Another terminology that also we might be aware of from our school days, that idiosyncratic drug reactions and exaggerated sensitivity. So here also this idiosyncratic drug reaction and exaggerated sensitivity, that is also another cause where the qualitatively actually distinct from the known pharmacological toxicities that are what we are aware about that particular drug. And this can arise from genetic differences in the patient. Say for example, primaquine causing non-immune hemolytic anemia in patients with G6PD deficiency, or azathioprine toxicity that is developing in patients with TPMT, that is thiopurine methyltransferase deficiency. Nowadays, we can estimate also these things in a particular category of patients, to make sure that this category of patients do not suffer from this kind of hypersensitivity reaction. Why it is important to differentiate between these categories, I mean the small molecule or large molecule, because it is very much important to differentiate between the drug hypersensitivity reaction elicited by small molecules used as medication, and the DHR induced by large proteins used as medication, that is monoclonal antibodies, because the mode of action and the resulting adverse drug reactions, that also differs substantially, and that also triggers the management approach. So that is why it is very much important to identify the cause. What is the probable cause for the drug hypersensitivity reaction, and accordingly the physician can approach to the patient. If we look into a broad classification of DHR, maybe in the next week upon this topic, we will have a separate seminar on drug allergy. But just for our understanding, I have put this slide, that it can be classified based on the timing of symptom onset. It may be immediate or delayed. Mm, Based on the mode of action, that is the drug allergy or immune reaction, pharmacological interaction with the immune receptor, that is also known as PI reaction, and the drug intolerance, or sometimes it is also known as pseudo allergy. Another category is that is based on the immunological mechanism that we are very much familiar with, that is type 1, 2, 3, and 4 reactions. Upon these, we will touch mainly the type 1 reactions. Now this type 1 reaction uh, is sometimes also interchangeably used as immediate type of reaction, because it happens usually within 1 hour, and it is IgE mediated. What we can see in the first row of this table, the mechanism is very much known, that antigen exposure actually causes the IgE mediated activation of the mast cell and basophils, with release of the vasoactive substances such as histamine, prostaglandin, and certain kind of leukotrienes. And what are the different kinds of presentation that may vary from anaphylaxis, angioedema, bronchospasm, urticaria, or hypotension. Apart from that, type 2, 3, 4 reactions are there, but today we are not focusing on this. So moving to the next slide, that is a little bit more about the pathogenesis. It happens in presence of drug specific IgE, but a small minority of patients from drug specific IgE upon exposure to a medication happens, while most do not have a prolonged treatment. That means there must be a interruption in the treatment, and that actually triggers the subsequent exposure. Now, once the antibody is formed, the drug specific IgE actually occupies the surface receptors on mast cells and basophils throughout the body. If the drug is encountered again, even if a metabolite of the drug also encounters, that may bind to the IgE molecule, causing the cross linking of the receptor and activation of the cells, and that causes the symptoms of type 1 reaction. And if it is anaphylaxis, the features of anaphylaxis also comes. IgE mediated reactions are dose dependent, although this may not be clinically apparent because sometimes even at very low doses they can cause severe systemic symptoms. Coming to few clinical features of type 1 reaction that can be varied, that we have seen in the previous table. The signs and symptoms of type 1 reactions are directly attributable to the vasoactive mediators released by the mast cell and the basophils. Now, upon different kinds of signs and symptoms, most common are urticarial rash, pruritus, flushing, angioedema of the face, extremities, or laryngeal tissues, and this can lead to the throat tightness with stridor or rarely asphyxiation. Next, apart from this, wheezing is there a possibility, gastrointestinal symptoms also a possibility, and or hypotension. So all these we have to take in our mind, keep in our mind as a clinical features of type 1 reactions. Now, anaphylaxis is the most severe presentation of an IgE mediated drug reaction. Here, the mast cell tryptase and the histamine can be elevated in the circulation in the first several hours after anaphylaxis, and the detection of these mediators implicates mast cells and basophils in the reaction, supporting the diagnosis of anaphylaxis. Sometimes this tryptase is also measured from in the laboratory. uh, Coming to few terminologies, we are aware about these two terminologies, anaphylaxis and anaphylactoid reaction. Anaphylaxis is traditionally means which is reserved for IgE dependent events, and anaphylactoid reaction is, it is usually used traditionally, I would say, that it is IgE independent event. But WAO, that is World Allergy Organization, they have proposed discarding this nomenclature, and they have proposed a different nomenclature, that is whether it is immunologic or non-immunologic. What is that classification? The immunologic anaphylaxis can be IgE mediated reaction, uh, can be IgG, but in human it is usually not found. And last one is the immune complex or complement mediated reactions. Usually the some of the drug reactions, these complement mediated reactions happens. Non-immunologic anaphylaxis is usually caused by agents or events that induce the sudden massive mast cell or basophil degranulation in the absence of immunoglobulins. Here also under non-immunologic, majority of the drug induced anaphylaxis comes. Now, what are the symptoms and signs of anaphylaxis? We can see from this table that in the skin there are certain kind of features that we are not going into detail about this table because almost all of us are aware about the some of the symptoms of anaphylaxis. But just for recapitulation, we have put this slide here, that in the skin, in the oral cavity, also itching or tingling of the lips, edema of the lips is a possibility. Respiratory, some features might come. Gastrointestinal, cardiovascular, in neurologic features may come, that is anxiety, apprehension, sense of impending doom. Ocular, periorbital itching, and sometimes uterine cramps in women and girls. That also we have to keep in our mind. regarding timing of onset of type 1 reaction, that is very important, because already we discussed that it is an immediate type. uh, it can vary with the clinical setting and the presentation. IgE mediated reactions occur rapidly after the last administered dose, which underlies the designation immediate. That is the reason why it is called immediate type. Time to onset is usually influenced by the route of administration. If it is IV administered medication, that the symptoms can occur within seconds to minutes. Upon oral administration, that can happen within 3 to 30 minutes if it is taken in an empty stomach, and if it is taken with food, it can happen in a, duration, range of 10 to 60 minutes. Commonly implicated drugs, there are, apart from these drugs, there are lots of other drugs, but very commonly used drugs amongst those: beta lactam drugs, penicillin, cephalosporins, neuromuscular blocking agents, quinolones, platinum containing chemotherapeutic agents, foreign proteins including chimeric antibodies, are the very commonly drugs that can cause this anaphylaxis. Now, one very important question sometimes come in our mind, that whether a previous exposure is mandatory for anaphylaxis. Now the answer is both yes and both no, because IgE mediated reactions generally require previous exposure to the drug in question. That is the science behind the IgE mediated reaction. Now, absence of a known prior exposure does not exclude an IgE mediated reaction, because sensitization may have occurred from exposure to a cross reactive compound, even though the patient showed no signs of allergy to the sensitizing product, that is the previous product. We can look into an example. A significant percentage of patients experiencing anaphylaxis upon first exposure to neuromuscular blocking agents are believed to have been previously sensitized through the use of various cosmetics, personal products, and non-prescriptional cough remedies that actually contain a tertiary and quaternary ammonium group. And the ammonium groups shared by all of these agents are highly immunoreactive and can induce cross-reactive IgE antibodies. That's why in the previous slide I said that the answer is both yes and no. Coming to few comorbidities and concurrent medications that might impact the severity and treatment of anaphylaxis. This part Dr. Shambo might touch, so I'll just touch few points that is important, that the as comorbidities like asthma, other pulmonary disease like COPD, ILD, cardiovascular disease, mast cell disorder, uh, mast cell activation syndrome, all these are the comorbidities, and concurrently administered medication like beta blocker, alpha adrenergic blocker, angiotensin converting enzyme inhibitor, angiotensin 2 receptor blocker, TCA, that is tricyclic antidepressant, monoamine oxidase inhibitor, some of the ADHD medications, which are actually stimulants such as amphetamines, recreational use of cocaine. These drugs we have to keep in mind, because that might impact the severity and the treatment part of the anaphylaxis. Coming to diagnostic criteria, there is a clear-cut diagnostic criteria for anaphylaxis. The anaphylaxis is highly likely when any one of the following three criteria is fulfilled. What are these three criteria? Number one is acute onset of an illness, that is within minutes to several hours, with involvement of the skin, mucosal tissue, or both, and at least one of the following, that is either a respiratory compromise or reduced blood pressure. Next point is two or more of the following that occur rapidly after exposure to a likely allergen for that particular patient. That happens, the duration is also very much fixed, that is minutes to several hours. Under that, what are the points we have to keep in mind? That is involvement of the skin, mucosal tissue, respiratory symptom, blood pressure, and the persistent gastrointestinal symptoms is there or not, like crampy abdominal pain or vomiting. Next is reduced blood pressure after exposure to a known allergen for that patient. Here we can categorize it into infant and adult, and there is a particular BP cutoff for particular group of patients. for confirmation of the diagnosis of anaphylaxis, we can retake in the left-sided flowchart. We can see that the retake the history of each episode from the patient, family, caregiver, and friend. Symptoms we have to take very much in detail. Time between exposure and symptoms, cofactors that might amplify the anaphylaxis, concomitant medical conditions, concurrent medications, ethanol consumption, patient's account of what treatment was given, and the effect of each intervention. These we have to take in very much detail. Review the relevant medical records for signs, symptoms, and treatment, whether emergency medical service or emergency department or hospital. Review serum tryptase results if it is possible, if performed at the time of reaction. Consider the differential diagnosis of anaphylaxis. What are the differential diagnoses that is given in the right side? Amongst those few are acute hives, acute asthma, anxiety or panic attack, syncope. There is a long list in the differential diagnosis of anaphylaxis. Determine the certainty of the diagnosis of anaphylaxis, whether it is certain or probable or unlikely or excluded. Thank you.
Thank you, Sumallo. Yeah. Thank you, Sumallo.
Thank you, Nasir sir.
Thank you, Sumallo. It's a nice presentation, but one query is that can I ask you questions now or after the whole session is over? Interaction can be allowed now.
I think better
Hello,
completion of the session, we can go for the questions.
Sumallo.
Yes, sir. I mean, if the presentation is over, and after that, if we
Yes,
have a discussion, that maybe.
are you audible?
Yes, sir. Yes, sir. We can hear you.
Chiranjeev, hello. Chiranjeev, can you hear me?
Hello.
Chiranjeev, can you hear me?
Yes. Am I audible?
Chiranjeev, I am thinking that
Oh,
better complete the session and then we can go for the question answer.
I think Sumallo's connection network is not working well. Sumallo.
Sir, can you hear us? Hello? Okay, take it on.
Am I able?
Sir, I think your sound is not.
আম্বো একজন স্যারের ঘরে গিয়ে একবার বলেছো না?
একটু বলে যে এখানে চলে আসছে। বলে এখানে লোক নেই, এখানে চলে আসছে। এটা নেক্সট প্রেজেন্টেশন। Shall I start?
শোনা যাচ্ছে না, শোনা যাচ্ছে না আমাকে। আমার নেটওয়ার্ক ঠিক আছে, আমার নেটওয়ার্ক তো দেখতে পাচ্ছি না স্যার। পরে তাহলে ঠিক আছে, আমার ঠিক আছে, আমি তো দেখতে পাচ্ছি।
You can start. Is the presentation fine? Presentation complete. So, am I audible, Sumal Dada?
Yes, Ambo, you are audible.
Yes, you are audible.
Okay. Okay. Good afternoon, my respected teachers and my colleagues. So today we are talking about type 1 hypersensitivity reaction. I will try to cover the management portion of type 1 hypersensitivity reaction, focusing on the anaphylaxis. But before starting my presentation, I just want to ask respected delegates, is there any relationship between all these pictures? Anyone can unmute and can let us know what is the relationship between this 1, 2, 3, 4 and 5 pictures. So at the extreme top left, we can see the normal airway, then there is a spasm, then sole and middle layer, and then the mucus flux. So this is the symbol of which disease? Anyone want to comment?
Bronchial asthma.
Yeah, it is asthma. Now bronchial term is now obsolete, so it is asthma. Next, here is eye. You can see the redness, and there is a cobblestone appearance in the upper eyelid. So what is this?
Is it vernal spring catarrh?
Yeah, this is allergic conjunctivitis.
Yes.
Next, this picture often we are now missing in our clinic because this is covered with mask. But this is a typical sign, salute sign we can say, and this is the ridge, salute ridge. So what is this signifies? Along with this nasal speculum examination, this boggy, pale, inferior turbinate, this signifies?
Allergic rhinitis.
Yeah. So this is allergic rhinitis. Now this gentleman has a swollen lip. That means this is, what is this?
Angioedema maybe.
This is angioedema. And along with that, there is some hives. So this is urticaria. So what is the relationship between all this picture? All these are generally mediated with, these diseases are mediated with type 1 hypersensitivity reaction. But today we will talk about the disease which is known as anaphylaxis. So this will be my next 15 minutes agenda. How to early identify the anaphylaxis, and why, how to initiate treatment immediately, and is there any clinico-pharmacological considerations. So regarding identification, it is most important thing is that, or we can say the hallmark of anaphylactic reaction is the onset of some manifestations within seconds to minutes after introduction of the antigen, generally by injection of less commonly or sometimes ingestion. So there will be upper and lower airway obstruction, or it can be both. There is some laryngeal edema, lump in the throat filling, hoarseness, stridor, bronchial obstruction, followed by chest tightness. There will be wheezing, flushing with diffuse erythema and warmth filling. And we can see a characteristic feature like eruption of well circumscribed discrete cutaneous wheals with erythematous raised serpiginous border and blanched centers. So these are generally called as urticarial eruptions, and they are intensely pruritic, and often it is associated with angioedema. So this, by inspection, we can find these signs, and we can identify there is some anaphylaxis. And if we just see the different percentage of different types of system involvement, so there we can see the cutaneous involvement is the most common presentation. So 85 to 90% of the anaphylaxis patient will come to us with urticaria and angioedema. Apart from that, there will be flushing, pruritus, sometimes, very rarely, there will be pruritus, but without any rash. 50% cases, there will be associated respiratory symptoms like dyspnea, wheeze, upper airway angioedema, there will be rhinitis, and there are some, as there is development of hypotension, there will be dizziness, syncope. 30% cases, there will be nausea, vomiting, diarrhea, cramping pain. So gastrointestinal manifestations will be there. There are some atypical presentations like headache, substernal pain, seizure also. So these four are the essential questions that to be asked for any patients who are suspected to develop anaphylaxis. So number one, where the cutaneous manifestations? are there or not. Specifically, we will search for pruritus, flushing, urticaria, or angioedema. Was there any sign of airway obstruction that involves either the upper airway or the lower airway? Where the gastrointestinal symptoms are there, like nausea, vomiting, diarrhea, or we should search for syncope or pre-syncopal symptoms. And regarding while seeing the anaphylaxis patients, we also think of the differential diagnosis like vasodepressors or vasovagal actions, vocal cord dysfunction, acute attack of anxiety. This is very important, but because in case of some injection, this panic attack appears, and that associated with hyperventilation syndrome, and that mimics like anaphylaxis. So we have to distinguish between hyperventilation or panic attack with anaphylaxis. Obviously, there may be chance of myocardial dysfunction, pulmonary embolism, foreign body aspiration, some acute poisoning, hypoglycemia, seizure disorder, metastatic carcinoid, or in case of hereditary angioedema, the patients may present to us with anaphylaxis-like features. So the immediate intervention just after diagnosis of anaphylaxis, we should not spend much more time before initiating treatment. And for that, the A is that assessing the airway, most important, then breathing, circulation, and the level of consciousness. Whether there is some altered mentation or disorientation, that may be an early sign of hypoxia. And after that, we have to administer adrenaline. So adrenaline is the most important drug that we should keep in our mind, and the dose of that is aqueous adrenaline 1:1000 dilution, 0.2 to 0.5 ml intramuscularly. And this is to be noted. Why this is, I will come in later. The lateral aspect of the thigh, or we can also give subcutaneously every 5 minutes as necessary to control the symptoms. And we have to obviously we have to see the blood pressure and how to increase the blood pressure. And apart from that, there are some other therapy we have to consider, and that depends on how the patient responding to adrenaline therapy. The most important part is facilitation of the patient to the critical care unit. How we can transfer the patient to the critical care unit, that should be we should consider that. And how we position the patient, that is again a very important thing. Place the patient in recumbent position and elevate the lower extremities. It is very important. But if in case of vomiting, the patient should be turned in one side. And obviously, while elevating the lower extremities, we should ask the patient if he is conscious, whether he can tolerate that symptomatically or not. We have to establish and maintain an airway, and for that, we should have some option for surgical interventions also, because sometimes we need to do some emergency cricothyrectomy, and there is importance of oxygenation, inhalation of short-acting beta-2 agonist, intravenous fluid replacement is very important. We have to consider the diphenhydramine, which is an H1 antagonist, ranitidine, H2 antagonist, glucocorticoids. But it is important to note that the glucocorticoid should not be the first option. It is the first priority should be given to epinephrine. Glucocorticoid we can use. It has no effect on acute episodes, but it prevent recurrent or protracted anaphylaxis. As the Shumaloda told beautifully about the pathogenesis of anaphylaxis, though the anaphylaxis is one type of immediate type of reaction, but again we can divide it anaphylaxis into two groups: early symptoms of anaphylaxis and late symptoms of anaphylaxis. So early symptoms of anaphylaxis, that means the problem is in the mast cell and already sensitized mast cells, when the Ig and the antigen complex bind with that mast cell, the Fc epsilon receptor 1, so that mast cells generally degranulate and there is a release of histamine. So that causes acute type of reaction. But what is responsible for this late type of reactions, which may occur up to 72 hours of the first onset? That is generally when again the mast cell, there will be formation of newer histamines, and the mast cell, we know the membrane of the mast cell that is made up of phospholipid, and that phospholipid generally lies by the phospholipase enzyme, and that becomes much more activated during this anaphylaxis by the stimulation of interleukin 4, and that phospholipid will break down to arachidonic acid, and we know that different prostaglandins and other mediators will be formed like leukotrienes, so on. So that reaction is responsible for the late reactions of anaphylaxis, and to prevent that late reaction, the glucocorticoids have a role. So early initiation of adrenaline or epinephrine is important, and then we have to switch to then we can add glucocorticoid or corticosteroid. So in some patients who are poorly responsive to intramuscular epinephrine, or we have not that much time for emergency transport or prolonged transport is required, there we should think about intravenous epinephrine. This should be used in profoundly hypotensive patients or patients in cardiorespiratory arrest. Already cardiorespiratory arrest happened, who have failed to respond to intravenous volume replacement and several injected intramuscular dose of epinephrine. There we have no other option. We have to give epinephrine intravenously, and this is the solution. 1:1 lakh, and we should give it 0.1 milligram via the infusion pump. We can see this rate. So initial drug of choice, so there should not be any confusion on that, the adrenaline, and this is the concentration already discussed. Time to highest blood concentration, that means Cmax, in asymptomatic subject is shorter when injection is given intramuscularly in the vastus lateralis than when it is administered either subcutaneously or intramuscularly in the deltoid muscles of the arm. So this is why it is better to give lateral aspect of the thigh. But this has no outcome data that compare these two type of administration. But it should be noted, adrenaline should be administered every 5 to 10 minutes necessarily as soon as the diagnosis of anaphylaxis is suspected. And this time interval can be shortened as per the physician's or clinician's decision. So position of the patient is important. Supine position, elevate the lower extremities, particularly when there is concern of hemodynamic compromise. This slows the progression of the hemodynamic compromise. The hypotensive patients should remain recumbent until the cardiovascular system has been stabilized and they are completely asymptomatic. There are some instances when the patient becomes upright from the sitting positions prematurely, then that causes sudden deaths. So we have to be very cautious regarding the positioning of the patient. Next is the oxygenation. Oxygenation is important, specifically when the reaction is prolonged, patient is drowsy. Pulse oximetry is a good guide to oxygen treatment, and if we have facility, the arterial blood gas analysis can govern the oxygen therapy. Fluid resuscitation. It is again very important because persisting hypotension despite epinephrine injection, that warrant we should give intravenous crystalloid solutions or sometimes colloid volume expanders. But again, here we should also consider that there are some instances, some examples of colloid volume expanders which may be allergic. So it is better to choose crystalloid solutions, and among the crystalloid solutions, normal saline is generally preferred in this type of distributive shock. And large volumes of fluid is required, specifically when the beta blockers. The patients are on beta blockers. They are very high risk patient when they develop anaphylaxis. So generally 1 to 2 liter of normal saline we need to administer to these adult populations at the rate of 5 to 10 ml per kg in the first 5 minutes, and children should receive up to 30 ml per kg in the first hour. Adults receiving colloid solution should receive 500 ml rapidly following slow infusion, but again we should be very much cautious regarding the volume overload. What are the other medications? We have inhaled beta 2 agonist, because we have to correct bronchospasms if it is not responding to intramuscular epinephrine. We can use epinephrine nebulization also. Role of vasopressor, specifically in presence of shock. The choice of vasopressor is dopamine, and we have to titrate to maintain the systolic blood pressure greater than 90 millimeter of mercury. And if the epinephrine injections and volume expansion fail to alleviate hypotension, we need this dopamine. And there are some studies are ongoing on vasopressin also, but it is not still recommended. Diphenhydramine is the H1 antagonist of choice, may be given intramuscular by slow intravenous infusion. The dose is 25 to 50 milligram in adults. In less symptomatic patients, or the patients who can able to take food, they also can be given the oral formulation of H1 antagonist, first generation or second generation antagonist. But it is important to note that often in ward or sometimes we use Phenergan. Phenergan is a very commonly used drug that generally used sometimes in case of anaphylaxis in many centers. But it is to note that this promethazine should not be used specifically in anaphylaxis, because it can it increases the chance of muscle necrosis. So it is not to use promethazine. Parenteral ranitidine, the H2 blocker, is better when combined with H1 antagonist compared to the only giving the H1 antagonist. Glucocorticoids, as already told, it has no acute effect, but it can prevent protracted anaphylaxis. So there are some proposed therapies for anaphylaxis like leukotriene modifiers, but the role of this is again controversial. Tranexamic acid can be used specifically when anaphylaxis is associated with DIC, nitric oxide synthesis inhibition via methylene blue. There are some studies on that. They show some promising result. So these late phase reactions can occur 4 to 6 hours after the initial reaction and can be as severe as or worse than the original reaction. So we have to be very cautious. We should not discharge the patients after 2 hours or 3 hours if the patient has anaphylaxis. And there are some cases when we found that late phase reactions can occur 72 hours later also. So education of the patient is very important, and it is better to observe the patients at least 72 hours when one episodes of anaphylaxis that happen. So this is one general questions to all of you. What is physiological antagonism? Anyone can volunteer, please. What is physiological antagonism?
It is when the antagonism is produced by action on a different receptor.
Yeah, exactly. So a drug that produces the opposite physiological effect to that of an agonist will indirectly oppose the action of the agonist. So for example, we can take as glucagon is a physiological antagonist of the action of insulin, and we can use it to treat the hypoglycemia that induced by insulin. So here, in case of type 1 hypersensitivity reaction, we have generally one direct physiological, very good example of physiological antagonism. That is, Shumaloda has described why histamine is important. The main pathogenesis behind the anaphylaxis is due to this histamine. So to counter that histamine, we have adrenaline. So they are not acting in the same receptor, but they are antagonism their respective action. But another physiological antagonist also we can use in some instances. Specifically, if a patient is on beta blocker, then it is sometimes very difficult to get the optimum benefit from the adrenaline, and that is the time when we should choose another physiological antagonist, that is glucagon. And we know that glucagon is available as injection, and if we can use this glucagon, that can generally acts as a physiological antagonism. It negates the activity of the beta blockers and gives some benefits to the patient. But again, when giving glucagon, one thing is important to note, because glucagon causes severe emesis, and for that generally we make our anaphylactic patients supine. But when we are giving glucagon injection, it is mandatory to make the patient turn into one side to prevent that aspiration. So it is very important to note this thing while giving glucagon. So physiological antagonism is this is also an example of glucagon. So here we can say that glucagon is a physiological antagonist to beta blockers while we are using this context. So this is the summary. Is the history consistent with previous episodes of anaphylaxis? If it is yes, then we can consider the allergist or immunologist or contact. Then we have to find that is cause readily identified by history. Already mentioned what are the important features of history. So is cause readily identified by history. So our further diagnostic tests are indicated generally in acute setting. No diagnostic test required. There are some tests we may say the trip test value, but these are very costly tests and not generally added much higher values over the clinical decisions. For future, we can plan allergy skin test or in different in vitro test. In case of drug, we can think of lymphocyte proliferation test. So if it is yes, then we have to confirm the diagnosis of anaphylaxis. Then there are some general advice that patient education, risk assessment. We have to consider whether we have to calculate the risk benefit between SE inhibitors, beta blockers used to this particular of patients, and also the angiotensin receptor blockers. And if a patient is taking tricyclic antidepressant or serotonin SSRI, then also we should be very cautious, because this tricyclic antidepressant and SSRI may mask the initial symptoms and signs of anaphylaxis. And also, this is not generally that much available in Indian context, the self-administered epinephrine injection. But this is very important the patients who are suffering from recurrent attacks of anaphylaxis. Specifically, the avoidance is the key mantra to them. Immunotherapy, desensitization, graded challenge, and pre-medications are required specifically in case of radio contrast medium. And here I just want to mention a little in a small that radio contrast medium, generally what Shumaloda had told previously beautifully about that anaphylactoid reaction. Radio contrast mediums are mostly responsible for that type of anaphylactoid reaction, though these terminologies are now changing. This is important. We have to be very much prepared for anaphylaxis, because though it is a very rare condition, but if happened, we have to be prepared. And for that, we have to keep all those drugs, all those instruments, whatever we discussed. Then after initial assessment, supports potential anaphylaxis, or sometimes non-localized urticaria may happen after some vaccination. Then also we have to assess the airway, breathing circulations and mental status. We have to inject epinephrine, supine position. These all are mentioned. This is the chart we can follow. And the auto-injectable epinephrine, again, it is a very important one who suffer from recurrent attacks of hypersensitivity, type 1 hypersensitivity reaction, and when to consider glucagon, when to consider intravenous vasopressor, those are already discussed. To coming the conclusion, the early diagnosis is very important for type 1 hypersensitivity reaction from treatment with ABC and injection adrenaline. That is most important. After that, after giving the treatment, we need to take the detailed history. So detailed history is not required before giving the treatment because the time is very important here. Then we have to observe the patients. We already mentioned the possibility of late onset or late complications of type 1 hypersensitivity reactions. So we have to at least observe for 72 hours. And this is important for all of us. We have to be prepared. So thank you. And this is the thing, though the type 1 hypersensitivity reaction is very much treatable, but sometimes fatality may happen. Sometimes that can happen, but we during the course of treatment should consider. We should not consider regarding the outcome. We should treat as early as possible. So thank you very much. Now, may I request Shogotoda to give us some light on the receptors mechanisms specific to the anaphylaxis. Thank you.
Thank you, Shambhu. Thank you, Shambhu.
Sugata, should I upload the presentation from my end?
Please do this.
Yeah, sure. Is it visible?
Yes, Somalo, it is visible. So my presentation is on the pharmacology, that is receptor pharmacology and clinical pharmacological aspect of anaphylaxis and its management. It may overlap the area of the Sambo and Sumallo. I am sorry for that. Now, before this two presentation was very beautiful and they already covered all the topic. Now I'm focusing the receptor that is involved in pathogenesis vis-a-vis treatment, and it is the utilization of the physiological antagonism. Now Sambo already have told about the physiological antagonism. I just want to highlight one point. It is the two agonist or ligand. It is the two agonist or ligand that act on different receptor of a same physiological system. Different receptor of a same physiological system and counterbalancing the effect of each other. Like as Sambo already told, this glucagon and insulin, this histamine as well as this epinephrine or adrenaline. Now these are the receptor, that is histamine receptor H1, H2, H3 is mostly responsible for the pathology of this anaphylaxis reaction. Now hypotension, it is due to this H1, H2 and H3 reaction, H3 receptor action. You know that H1 receptor act, it is a GQ coupled receptor act via IP3-DAG. H2 is GS coupled and H3 is GI coupled. Now this H1 and H2 act simultaneously on vessels. Mostly the H1 receptor is present in the endothelium and H1 H2 both is present in the atrial musculature. Now when H1 is present in the endothelium, it will increase the NO synthesis by inos action. H1 increase calcium concentration, activation of the inos and increase NO. By the virtue of the cyclic GMP, NO ultimately dilate the vessels. But when it act on the musculature, H1 can cause vascular constriction. But H1 effect in the endothelium by NO is more pronounced than that H1 in the muscle. Now H2 action. H2 that is histamine 2 receptor is more cyclic MP it produce. It is GS coupled receptor. So ultimately, by the virtue of increasing cyclic MP and then PKA effect and myosin light chain kinase, ultimately it causes relaxation. So by both action H1 and H2, arterial wall is become relaxed and there is a profound vasodilation and thereby hypertension. Now H3 receptor, it is usually present in the presynaptic region of noradrenaline neuron. So when H3 is activated, it reduces the secretion of the noradrenaline. So there is also reduce the action of the alpha receptor. So ultimately vasodilation. So hypotension is responsible due to profound vasodilation by H1, H2, and H3 mediated action. Now coming to the laryngeal edema or angioedema. It is the combined action of the H1, H2. It is actually the deep dermis, subcutaneous, and submucosal tissue swelling due to vascular leakage. This is only a associated part of the vasodilatation. Now coming the bronchospasm part. This is by H1 receptor mediated, and you know IP3-DHE is cause muscular contraction. So there is a profound bronchospasm and respiratory difficulty. Now coming the antagonism part. Somalo, please next slide. Now this all hypotension, laryngeal edema, and bronchospasm, this all three part each counterbalanced by this adrenaline. Hypotension, it is by alpha-1 receptor and alpha-2b receptor, both IP3-DHE and reduced cyclic MP, this is GS coupled receptor, ultimately cause vasoconstriction, thereby counterbalance the effect of the histamine. Laryngeal edema also counterbalanced by the alpha-1 receptor by reducing vasodilation as well as vascular leakage. Bronchospasm by beta-2 receptor by increased cyclic MP, it relaxes the bronchial muscle and thereby oppose the action of the histamine. Now decrease histamine release. Adrenaline have the fourth action because in the mast cell and basophil there is the beta-2 receptor, and when this beta-2 receptor is occupied by the adrenaline, there is a reduce in histamine release from the mast cell as well as basophil. So here the fourth action, reduce histamine release is also taken care of by adrenaline. Next slide, please. Now this is the clinical pharmacological aspect. Most of the part is covered by our previous speaker. Now what is the safety of adrenaline? We must admit one thing, because there is a rapidity of onset of this anaphylaxis reaction and it is totally unexpected, and with treatment is rapidly recovered. So there is a few or literally no a placebo control or a active control clinical trial on this acute anaphylactic reactions. So most of the data that is we have, this is from the evidence and clinical knowledge of from the experts, and it is true the adrenaline intramuscular the treatment for anaphylactic shock. Now is it when there is a risk, safety and benefit, risk and benefit. Benefit is there when there is risk. If the patient have concomitant disease, cardiovascular disease like arrhythmia, like ischemia, like hypertension, this particularly patient have a risk, and mostly in the elderly person. Because if we come from the receptor part, in the coronary circulation, there is a big difference. Here, the histamine ultimately increase vasoconstriction in the coronary vasculature, because those patients having the coronary artery disease, there is a dysfunction of the endothelium. So release from that particular endothelium is quite reduced. So for this patient, the predominant effect is coronary vasospasm. So one of the cause of death in this anaphylaxis shock is due to coronary arteriospasm and thereby myocardial infarction, and there is a arrhythmia. So from this aspect, there is a risk from those patients having particular cardiovascular disease, but benefit is most important. But in spite of having known cardiovascular disease, arrhythmia, we should have proceeded to give adrenaline, because if we do not treat this patient, there is a chance of more arrhythmia and more infraction due to severe hypotension and reduced coronary circulation. Now, coming to the best route of adrenaline administration. Obviously, the best route is, as told by the Sambo and Sumalo, it is IM, because there is a trial. This is not a trial. This is from the retrospective and resistive analysis. They have seen that those patients given subcutaneous, there is a less Cmax and more Tmax. The time of action is prolonged up to 32 minutes, whereas for IM it is only 5 to 8 minutes. And the Cmax is also low for those patients having subcutaneous injection. So IM is always preferable. Now come to the international. Dr. Bhaskar have asked this question also. For international, there is no head-to-head trial from international and intramuscular route, but there are some trial. The 3 milligram of aerosolized adrenaline is given. There is a quite amount of this adrenaline is present in this blood, but it is not up to the mark of IM dose. And this data, the second study, the data was conflicting. So international route is not preferred nowadays. And the best route is always then intramuscular and IV. Dr. Sambu has told very good, very nicely that when it is given in the IV route and what is the dilution. Now, what is the appropriate dose? Here also there is some debate in the appropriate dose from the American authority and European authority. The most commonly we found the dose 0.3 to 0.5 ml adrenaline of 1 is to 1000 dilution. This is from the American, but from the European guideline it is 0.5 to 1 mg. This is the dose, but there is obviously no head-to-head trial, but resistive-based analysis shows that there is no differentiation between this fatality as well as the efficacy. Now, when to give? As early we can detect and as early we give this adrenaline, as Sambo told earlier, the benefit is more pronounced. And there are 2 small studies. They have shown that if it is given within 30 minutes, the outcome is more better than if it is more than 45 minutes. Now coming to drug-drug interaction, this is already discussed in the previous session. That is the beta blocker, alpha blocker, tricyclic antidepressant, monoamine oxidase inhibitor, and cocaine. These can cause drug-drug interaction with adrenaline, because if we give the beta blocker, beta receptor is blocked. Now, if we give adrenaline, then there is an unopposed action of the only alpha receptor that may cause severe hypertension. Now, this severe hypertension ultimately causes bradycardia by NTS. This bradycardia ultimately cause cardiac arrest. So this is a problematic area. So here, if the patient on the beta blocker, the dose should be half, and monitoring of the pulse. And if this pulse is not much more, or is very much bradycardia is there, then better to go for the glucagon, as Sambo told, because glucagon increases the cyclic MP by calcium-dependent mechanism and not by the beta-mediated action, which is blocked by the beta-2 receptor, beta blocker. Now coming to drug-drug interaction, this alpha, if patient is an alpha blocker, then the hypotension will be prolonged, and this adrenaline is unable to overcome this hypotension, so there is a fatality. Now patient is on the TCA or cocaine. You know that these are the uptake 1 inhibitor, and so if we give the adrenaline here, there is a chance of more concentration of adrenaline in the neuronic end plate. So those should be reduced and preferably half. And if patient is the monoamine oxidase inhibitor, this is same enough here also. Now, what is the drug disease interaction? Now, if the patient have a known thyrotoxicosis, patient have asthma, coronary artery disease, hypertension, and arrhythmia, then we have to have a extra cautious to give adrenaline in the particular dose, because there is a chance of arrhythmia is more, and we have to prepare for other emergency treatment. And comorbidities that have the worst outcome, this all 5 have the worst outcome. Most worst outcome is seen with the asthma patient. And what about the antihistaminic? Now, diphenhydramine and chlorpheniramine both are used. Now, there is no head-to-head trial again, because this is a rapid happening event. So this control trial is not there. But some expert opinion is like that. the diphenhydramine has more anticholinergic effect, so that may ultimately increase the pulse more. And we are giving adrenaline. So chlorpheniramine have a least anticholinergic effect, so they prefer this. But it is that expert opinion only. And what about the colloid or crystalloid? Obviously, crystalloid is the better, because all colloid like dextran, like hydroxyethyl starch, and PVP, that is polyvinyl pyrrolidone, all ultimately increase the histamine release from the muscle. So there is a chance of increased histamine in the body. So better to give crystalloid here. And Sumala, next slide. And in summary, this is the summarization of the all topics, Sambo, Somallo, and me. This is anaphylaxis is a severe life-threatening reaction, and that can affect the all age group. The severity of the previous reaction does not predict the severity of the subsequent. It can be more fatal, it can be similar or less fatal. Intramuscular adrenaline is the first line treatment of anaphylaxis. Intravenous adrenaline only reserved for those unresponsive to other intramuscular dose, or there is a circulatory collapse. Early use of the adrenaline is associated with most improved outcome. So thank you.
Thank you, Saugata. Thank you very much.
Thank you, Sumallo, and thank you, Shambhu, for your very nice presentation. Informative presentation.
Nasir sir, your voice is not audible.
Okay, probably I was on the back seat. So,
Okay.
is it now audible?
Yes, sir.
Yes. So there is.
Now may I request Professor Pal to raise some views and provide his valuable comments in this session, end of this session. So, Professor, please. Professor Jyotirmoy, please.
Professor Pal, are you here? Professor Pal, can you hear us?
Jyotirmoy sir, can you hear us? Hello, sir. Shambhu, তুমি এটা জ্যোতির্ময় স্যারকে কল করো, স্যারেরটা মনে হচ্ছে মিউট রয়েছে। By that time, Professor Tripathi sir
In the
also
meantime,
there.
am I audible, Sumallo?
Yes, sir, you are audible.
Am I audible?
Yes, sir. Jyotirmoy sir.
Hello.
Pal is here. Hello.
Hello. শুনতে পাচ্ছ?
Yes, sir. আপনি কিছু বলুন। We are waiting for expert comment.
Yes. Thank you, Dr.
We are
Bakshi.
waiting for your expert comment, sir.
Yes. সেখান থেকে সিগন্যালে যেন আমার কথা বুঝতে পারছিলাম না। আচ্ছা, ঠিক আছে। ডক্টর বাগচি, থ্যাংক ইউ for invitation.
We are waiting your experts comment, sir.
Yes, sir. Am I audible?
Professor Pal.
Yes, sir, we can hear you.
Hello.
Professor Pal,
We can hear you, sir.
can you?
You can hear me, okay. So my comment is type 1 hypersensitivity, what you are discussed, this is very important for the clinical aspect, because more often we physicians face a challenge, not only the atopic disease or hypersensitivity disease, particularly allergic rhinitis is very common. Asthma and different type of atopic disease, also the drug reaction. Because of the drug reaction, how we can, because there are some of the drugs are very essential, but due to the drug reaction we cannot use. So understanding whether this reaction is preventable, so type 1 hypersensitivity understanding is very important. And one thing you have to remember, whatever the type 1 hypersensitivity diseases there, mechanism is not the same in everything. Suppose allergic rhinitis mechanism and mediator is different from the asthma pathogenesis and mediator. So the drug which is effective in allergic rhinitis may not be effective in asthma. So mediator and pathogenesis of different type 1 hypersensitivity disease you have to understand. That will be helpful in managing the cases of different type of hypersensitivity related diseases. So thank you, Dr. Bakshi. Hello.
Sorry.
And one thing I think I have to notice how drug desengineration. This is also to be discussed. How we
No, no, sir, why not? That is very important.
this is very important. How we can